Hello, so we are going again on by MiECC in ERAS, presented by Dr. Malvindi from Italy. Hello, Dr. Malvindi, how are you?
Good morning. Hello. Hello.
Okay.
Just going to share my slides. Yeah. So yes, we are going to talk about this MiECC in ERAS program. My name is Pietro Malvindi. I'm a cardiac surgeon and researcher. I work in Ancona with Professor Diosano. You know him, I know. And we are in an academic hospital. We are very, very close with our university. And I'm going to share with you some thoughts and some findings of our research and clinical practice. I mean, this is not off topic, but this is something that brings us to some reflection. So all we know that in the last decade was a great spreading of transcatheter procedure, especially for aortic valve stenosis. And it's not just a matter of how to inform the patient. I mean, we do perform TAVI on our own as surgeon, as we do surgery as well, of course. And we know that these are good operations, especially for frail patients, for high-risk patients. Aortic stenosis can be treated with low risk of mortality and stroke. And despite TAVI's major drawbacks that you cannot see in surgery, like a high rate of pacemaker implantation, paravalvular leak, major vascular complication, TAVI can provide a better recovery of some patients. And although this is not our typical TAVI patient, I can tell you that we can see that for can make the post-operative period much easier. Of course, from a pure surgical perspective, as a cardiac surgery community, we are doing very well. I mean, these are data coming from registry, worldwide data registry, and show that you can perform even complex surgery like mitral or aortic valve surgery with very low risk of mortality and stroke in the patient, with very good results in terms of late outcomes. But the requests of the patient are slightly different, or at least they got some other reasonable desires. From patient perspective, there is still room for improvement. So they want to have less tissue trauma, and they want to have maybe better cosmesis, but they want to have a smoother post-operative period and to stay just short time in the ICU or in the hospital. So what we have done in a surgeon in the last 3 decades, there was minimal invasive cardiac surgery spreading, and there are many meta-analyses showing that you can perform what is called minimal invasive cardiac surgery as safe and some same effectiveness as conventional sternotomy. And with some degree, minimal invasive cardiac surgery has been associated also with the lower rate of post-op transfusion or atrial fibrillation and lower stay, shorter stay in the ICU and the hospital. But these data are usually coming from dedicated heart valve center. If you just have a look at the daily practice on the real world, what is called minimal invasive cardiac surgery is just small cardiac surgery done through a reduced incision. And then if you look at the prevalence of the penetration of the minimal invasive mitral valve surgery in several countries, you can see that penetration is still low. And this is because many operators and many teams think that this kind of operation require a difficult learning curve, and operating through a smaller surgical field can affect your exposure, myocardial protection, the airing, and many times, most of this experience show that these operations are carried out with longer operative times, with cross-clamp time reaching almost 2 hours and CPB time over 2 hours. And this has been also very well highlighted in this review from our host today, that is a surgeon's perspective of doing something through a small cut. It doesn't mean that it's going to respect the physiology perspective, I mean to minimize the biological trauma of the patient. Another option we are pursuing in the last decade is just to minimize the impact of the extracorporeal circulation. And we know I follow the presentation since this morning. I mean, these are data, they are established the role of the minimally invasive extracorporeal circulation in reducing the bleeding, reducing the need of transfusion, reduce the rate of post-op AF. And but this is important to see that MiECC has a role, but need to be better evidence to promote a fast-track recovery, so maybe a better recovery, an easier recovery to the patient, and should be involved in a program that is not a single operator, single person program, but needs to be all the team needs to be involved. And lastly, another cornerstone seems to be the fast-track anesthesia. If you go and do your search, you see there are many papers talking about cardiac surgery and fast-track. But if you go in depth, you see there are very few experience, mainly on coverage patients, reporting outcomes and explaining how to do. Now, if it's safe to provide fast-track anesthesia for cardiac surgery patients. So very recently, I mean, there was also in cardiac surgery with some delay compared with other surgical specialty, ERAS approach has been promoted and implemented in cardiac surgery. Tomorrow will be also another session, a wide session on ERAS. I mean, this is a multidisciplinary approach that try to promote the recovery and to improve all the perioperative period, including the pre-op, operative and post-op phase. But if we have a look at this first recommendation, we can see that there is very little mention or no mention regarding the key action that need to be taken to improve patient care regarding what we have done so far. There is no mention about minimal invasive cardiac surgery. There is no mention about minimal invasive extracorporeal circulation. In 2022, other guidelines came and introduced that maybe normothermia should be preferred. I mean, in patients undergoing a cardiac operation. And again, that in some way an optimized extracorporeal circulation needs to be implemented, trying to reduce postoperative complication and hospital mortality. And again, if we go for a minimal invasive approach evidence, there is just an expert opinion talking about some favor towards video-assisted, I would say, minimal invasive mitral valve surgery. And finally, we got the last consensus came this year that just gave a low level of evidence of a goal-directed perfusion. So actually, this first pieces of recommendation for the ERAS program in cardiac surgery did not implement what we have done really so far in the last 3 decades. And we've done our own study. We did very recently a systematic review of what was on the first ERAS program. This paper included 14 papers, came from some pioneer center exploring the ERAS in cardiac surgery. And what we found, I mean, one of the aim of the study was to explore the protocols of these units. But we found that the important preoperative key action, you can see here, yes, education of the patient, pain control is usually important, but has been implemented in about 50% of the protocols. And again, also the importance of making the patient more fit before the operation, I mean, through a rehabilitation program was implemented in less than 50%. But we are more surprised when we went to look at the intraoperative key action. So all the action that we believe they are important to make better the operative journey of the patient. In this case, you can see that surgical access, fast-track anesthesia, and the implementation of minimal invasive extracorporeal circulation, or even an optimized extracorporeal circulation, I mean, were found in less than 50% of the protocols, of the actual protocols on ERAS. And again, post-operative reaction regarding the fast-track anesthesia, early extubation and pain control seems to have higher favor, but you can see here there were no much protocol proposed, and early extubation sometimes was with a mean mechanical ventilation time of 24 hours, so not really early. Now, what we have done is something that we, after this study, and we want to show what was our experience, or started our experience of why we are interested in these ERAS embedding, and not only the minimal invasive cardiac surgery, but also the minimal invasive subcorporeal circulation, and in some way, minimal invasive anesthesia. Everything started in 2016, that was the idea with this 360-degree mix, minimal invasive cardiac surgery, to get better involvement of all the actors in theater in the post-operative period, the surgeon, perfusionists, anesthesiologists, and physiotherapists. These efforts led ultimately to what we call the Ancona Ultra Fast Track protocol. So everyone tried to do the best possible to minimizing the trauma of the patient. Surgeons starting for the tissue trauma. So this is what we do. We favor the minimally invasive approach for aortic valve pathology. We prefer mini sternotomy or the transaxillary approach. We are not using now the right anterior mini thoracotomy. And again, also for mitral valve pathologies, we start initially with the usual video-assisted anterolateral incision. Now we prefer a direct Q transaxillary incision, because this way we are able to minimize the trauma and the tissue trauma of the patient. But we have this with this access, the transaxillary, because most importantly is associated cross-clamp time is around 60-65 to the patient. And we have introduced a systematic use of MiECC. This was on aortic valve patient. We did this study, and we found that patient undergoing minimally invasive extracorporeal circulation for the aortic valve surgery. So same patient operated a minimally invasive aortic valve, but patient with or without minimally invasive extracorporeal circulation. We found that adding a MiECC provide better results, and in terms of less bleeding, less post-op AF, less transfusion, but more importantly, MiECC was able to promote the ultra-fast track recovery. So more than 60% of the patients were managed through an ultra-fast track pathway. Other things that you can do also, trying to optimize your perfusion. For example, we don't do MiECC for mitral valve, but we changed, for example, our cardioplegia. It was at the end of 2021. After done an extensive review, we did a meta-analysis just to understand better the use and the results associated with the nido-cardioplegia, that we were not using at all before. We decided to start with the nido minimally invasive mitral valve surgery, and for us, it's working. Maybe it's a good suggestion for someone else, because we are able now to provide less volume, and importantly, there is a post-cross-clamp defibrillation. It's really rare in the nido. It's something important if you can avoid it. And with no change, no different in terms of myocardial protection, as we found that there was, according to the cross-clamp time, no difference in terms of post-operative peak of troponin. So this works, at least for us. We are doing the operation with the 60-70 minutes of cross-clamp time, so the nido is good. We can do a single infusion, a single delivery, and we are happy with our results. And again, even done this one, it's important to go with a very strong pain management of the patient, because if you can get the patient painless, then you can easily reach an on-table extubation. This is important. We are doing Every year, we are getting more familiar with the extubation of the patient straight in the operative theater. And this is important, not just because you say, okay, the patient is awake, it's important, you can see that they got no neurological issue, but because the patient 1 hour after surgery can be treated by the physiotherapist, and 3-5 hours after surgery can start some mobilization. We are treated with this, following this principle, so combining improvement in key action, in surgical access, extracorporeal circulation, and anesthesia. So far, it's more than 800 patients, and we're trying to provide evidence because this is important. Of course, we are happy with the usual hardened points as surgeon, like just stroke mortality. These are the basis of the treatment, and these are good both for AVR and also for mitral valve surgery. But what it is important is we want to see if there is any other improvement in the postoperative care of this patient. So this was this paper led by my colleague Paolo Berretta. He did a propensity match analysis on heart valve patients. They were aortic valve and mitral valve pathology patients treated through mini sternotomy, mini thoracotomy, and 1/4 of them using MiECC with reasonable time. And we found that usual results are okay. In hospital mortality is acceptable, stroke is fine, but using an ultra-fast track, so a combination and a global improvement of the care of the patient, led to a lower rate of respiratory failure, lower rate of reintubation, and this patient had no mechanical ventilation post-op. They stay less in the ICU, they stay less in the hospital. Similarly, we recently investigated the result of the application of this ultra-fast track protocol in mitral valve patients. So these patients are operated on mini thoracotomy and normothermic cardiopulmonary bypass. Nowadays, we're using only the cardioplegia and really aggressive pain management. So we want to see if this kind of approach will lead to an early extubation, maybe on table, and then to start and mobilize the patient as soon as possible. We ask, if it's feasible and safe to do, if there is any relevant clinical advantage associated with this protocol. What we found that patients that are extubated early, they are less than 6 hours, that is the fast track extubation, they stay less in the ICU, usually discharged on day 1. They stay less in the hospital, and they are usually discharged straight home without any need of further period of rehabilitation. And what we chase our protocol, let's say, if there is any meaning to extubate the patient on table, is something more that you can add. Yes, this is important because the patient can pursue this pathway of very early rehabilitation and early mobilization. And so, and again, this patient can benefit more of staying less in the ICU, and they are ready soon to go straight home without any further period of rehabilitation. So, of course, we found that, yes, this kind of approach is feasible. 80% of the patients went through this fast track course, and this is associated with a short stay in the ICU, short stay in the hospital, and we see the increasing discharge of this patient. Anyway, we are happy with these results, but we understood that, so we start from doing small incision, we start from doing minimally invasive optimized extracorporeal circulation, trying to extubate early the patient. This is important. This is a job of enhanced in-hospital management. But what we believe that there is another step, this step we are going to take in the next few months. So the patient needs much care also in the pre-admission phase and after discharge. So we want to expand what is the ERAS in cardiac surgery. For the reason we ask some help to our engineer of our university, and then they provide a website. So we're doing some telemedicine. And then the patient can be connected to this website, and they can take information about the operators, about the procedure, about the hospital environments. And you can see they can go for the virtual tour, and this is important because they can get familiar with what they are going to experience maybe in few weeks. And this we know can increase the compliance of the patient, can reduce the stress of the patient. There is also a good engagement also of the family of the patient with the operator. So with this virtual tool, we can provide enhanced information to the patient. These are the videos they can find on the website. They can receive information from the nurses, physiotherapists, anesthesiologists, perfusionists. I mean, there are. And another important aspect is trying to increase the fitness of this patient. What we have done is just to provide a tailored treatment before the admission of the hospital. This is based on the condition of the patient. They can go to a basic, intermediate, or advanced rehabilitation, and then they are told to do some breathing exercise, muscle strengthening, stretching exercise, or aerobics exercise. They can find all this information in the website, so they can come to the hospital, we hope, in better condition. And finally, there is another aspect that is always neglected, that is just the psychological evaluation and support to this patient. Cardiac surgery for younger patients is one of the worst things they can experience in their lives. And for maybe elderly patients is another problem adding to their frail status. So this patient needs to be also supported, and we ask the collaboration of our psychological and psychiatrist team at the university site. So finally, I'm going to conclude that we get strong achievement as surgeons. We know the cardiac surgery is a very high safety profile. And so now, should call to address this new request coming from the patient. We got to pursue new therapeutic targets regarding the length and the quality of the hospitalization of the patient. And we should improve an early mobilization and recovery. We know that surgical perfusion and the anesthesiologist technique, if they are integrated, they should work together within an ERAS evidence-based protocol. Can meet this request. So we believe that if you just provide a small cut, or just provide minimally invasive extracorporeal aspiration or small anesthesia alone, you are not going to achieve big results. So altogether can play a major role. And then, of course, we are called to provide new robust evidence, because all this data needs to be included in future guidelines. Finally, this is the base. We start with patients that they are relatively fit and low risk. This is important because you set up your team and your practice. But now, we are going to include frail and comorbid patients, because these patients are going to benefit even more from an established ERAS protocol. And so this is just last suggestion. You need to go think also outside the hospital what's happening. So a rehabilitation phase, the engagement of the patient before the admission is important as a strict follow-up after the procedure. Thank you.
Thank you. So, yeah, since we don't have much time, we only have short comments.
Thank you, Dr. Malvindi, for the excellent presentation. Anesthetic perioperative management is critical in promoting fast track, and effective pain management is a key factor. So are there any questions from the floor? No? Okay. One comment from Dr. Hajek, and later one comment from Dr. Sarridou.
I'm sorry, I will be a little bit provocative. I suggest be careful. Slow down with ERAS. Surgery must be perfect, but anesthesia, not so. We have no clear data about pharmacodynamics of pharmacokinetics of anesthetics during cardiopulmonary bypass. I didn't see clear benefit for table extubation. For me, the lower risk for patient is 1-2 hours of protective ventilation than the risk of underestimated hypoventilation after the surgery. Patients are more and more sick, older and older. This is the iatrogenic cardiac arrest, ischemic reperfusion injury. I will be so careful with it.
So, Professor Sarridou, would you like to comment?
Dr. Malvindi, thank you ever so much for this very thorough, impressively thorough presentation, I would say. Just one comment from my side. Definitely, undoubtedly, we can accept that a MiECC program can take only one step further the very good results of implementing an ERAS program. So they bond with each other very well, like a hand with a glove. It's very important to be able again to implement a good prehabilitation program. Prehabilitation, it's all very new to us. And it has shown very good results from studies that have launched very recently, not only on the good outcomes overall and the minimization of the hospital stay, but also on factors like atrial fibrillation. Atrial fibrillation is very important, it's fatal, and also factors like removal of chest drains. And here I would lastly add the importance of a good analgesia plan. You mentioned minimal invasive techniques. These are all very painful. And I would say that from our side, there is plenty of room for improvement. Peripheral blocks, parasternal blocks, paravertebral blocks can be very, very beneficial. And again, let me congratulate you for your excellent presentation.
Thank you very much. If I just close with a comment. Regarding the on-table extubation, yes, I mean, it's something needs to be carefully. We fully agree. I mean, we are talking about patient. We start this practice, we are implemented even more. In patient undergoing mitral valve surgery, most of the time is degenerative. They are 60 in terms of mean age. So it's something that is really put in a clear context. There is no doubt. And of course, now we are 80% of the patients. So I agree. It is something that it is important for us because it can open straight away the possibility of starting some mobilization. These are selected patients, no way. I mean, this is written and also in the papers we just published. So I agree. In terms of the role of the anesthetist is very important. We got really, I mean, fantastic partnership with them. So yes, the pain control, they are doing this radius block. They can perform also parasternal block because also in CABG patient, sometimes they try to do this early extubation. So controlling the pain is really, really important. Thank you.
Thank you. I also think nutrition will be very much helpful to complete the whole program. We will discuss it later. So, okay. Thank you very much.
Thank you very much. It was a pleasure. Thank you.